Hello everyone, my name is Niall London. I'm an assistant professor of otolaryngology at Johns Hopkins within the Division of Rhinology, meaning sinuses, and skull-base surgery, as well as the Division of Head and Neck Cancer Surgery. Today I will be discussing a recent presentation I gave at the American Academy of Otolaryngology annual meeting as part of a panel addressing immunotherapy for head and neck cancer treatment. The goal of cancer immunotherapy is to activate or harness the immune system to fight cancer. One type of immunotherapy that was a particular focus of our panel is known as immune checkpoint blockade. Immune checkpoints are natural aspects of our immune system that under normal conditions act as brakes to help prevent an excessive immune response. Cancer is able to utilize these natural mechanisms to avoid detection by the immune system. By blocking these checkpoints with immune checkpoint blockade, the brakes can be released, allowing the patient's immune system to recognize and destroy the cancer. One of these immune checkpoint mechanisms is programmed death 1 or PD-1, which is a co-receptor found on the surface of immune cells. This receptor interacts with a ligand called programmed death ligand 1 or PDL1, which is found on cancer cells. Targeting this pathway with immune checkpoint blockade has shown exciting results over the past 10 years for multiple tumor types. The purpose of my presentation in the panel at the American Academy of Otolaryngology annual meeting was to discuss the current indications for PD-1, PD-L1 immunotherapy for recurrent and metastatic head and neck squamous cell carcinoma. In particular, I discussed 3 key clinical trials, including Keynote 12, Checkmate 141, and Keynote 48, that have contributed to Food and Drug Administration approval for nivolumab and pembrolizumab, which are PD-1 inhibitors for recurrent or metastatic head and neck squamous cell carcinoma. To briefly summarize these trials, both Keynote 12 and Checkmate 141 included head and neck cancer patients that had been previously treated and were refractory to platinum-based chemotherapy and standard of care regimens. Both of these trials demonstrated that these agents are generally well tolerated with a response rate between 13 to 18%. The most exciting results, however, included a long duration of response, which has been a significant improvement over previous therapies. These trials led to the FDA granting approval in 2016 for nivolumab and pembrolizumab for the treatment of patients with recurrent head and neck or metastatic squamous cell carcinoma refractory to platinum-based regimens. The third clinical trial I discussed was Keynote 48, which was a multi-center randomized phase 3 trial of untreated, locally incurable, recurrent or metastatic head and neck squamous cell carcinoma. Patients were randomized into pembrolizumab alone, pembrolizumab plus chemotherapy, or cetuximab plus chemotherapy. This clinical trial found that pembrolizumab improved the overall survival in tumors with a combined positive PD-L1 score greater than or equal to 1, and was associated with substantially longer duration of response in all recurrent or metastatic head and neck squamous cell carcinoma patient populations. These results helped to support FDA approval in 2019 for pembrolizumab as frontline treatment for recurrent or metastatic head and neck squamous cell carcinoma, either in combination with chemotherapy or as a single agent in tumors with a combined positive score greater than or equal to 1. Thanks for listening today. It will be exciting to see future developments in immunotherapy for improving treatment outcomes for our head and neck cancer patients.